Imagine a physical environment actively collapsing inward. The perimeter of where you feel secure shrinks day by day, restricting your freedom of movement. Treating severe spatial phobias presents a mechanical problem. The cure requires the patient to confront the outside world, but the clinical facility designed to provide that cure is located within that outside world. The logistical friction of a traditional therapy intake is significant. To reach a therapist's waiting room, a patient must navigate unpredictable transit systems, crowded streets, and wide-open spaces. This physical requirement triggers the core pathology, often forcing a retreat before treatment begins. Agoraphobia is the primary driver of this structural failure. To understand why this condition requires a different delivery system, we need to map its exact diagnostic architecture. Telehealth functions as the mechanical bypass for this specific pathology. The traditional physical model of mental health care structurally excludes the patients whose pathology prevents physical travel. Agoraphobia is frequently misunderstood as a general fear of the outdoors, or categorized as housebound syndrome. The actual driver of the disorder is the fear that escape would be difficult, or help unavailable if panic-like symptoms were to occur in a given location. Historically, it was assumed to be a symptom of panic disorder. However, agoraphobia exists independently, with a lifetime prevalence of 1.3%. Recognizing this diagnostic independence is required for designing an effective intervention. Effective intervention focuses on expanding the patient's perceived zones of geographical control. Agoraphobia is a geographic manifestation of a perceived loss of internal control. The DSM-5 establishes agoraphobia as an independent diagnostic category. This categorization requires clinicians to evaluate specific spatial triggers rather than generalized anxiety. This diagnostic matrix identifies specific spatial criteria. The first two involve using public transportation and being in open spaces, such as parking lots or bridges. The next two variables cover being in enclosed spaces, like shops or theaters, and standing in line or being part of a crowd. The final criterion is being outside of the home alone. Diagnosis requires a marked fear or anxiety to be present in at least 2 of these 5 situations. This dual trigger requirement identifies a pattern of generalized spatial avoidance rather than an isolated phobia. In every instance, the avoidance is driven by the fear of incapacitating panic-like symptoms. Recognizing this multi-situational pattern is the first step in constructing an effective treatment plan.
This process requires a patient to step directly into a previously avoided environment to intentionally trigger their own fear response. The exposure is systematic. The patient starts with low-level triggers and slowly escalates to more complex environments. The patient must remain in the feared situation until their physiological panic response naturally subsides, recalibrating their neurological baseline. Selective serotonin reuptake inhibitors, or SSRIs, are frequently used as an adjunctive therapy to lower overall anxiety levels during this process. While medication helps mitigate physiological symptoms, the physical exposure work breaks the avoidance cycle. Clinical recovery demands controlled, sustained physical presence in the environments the patient has previously engineered their life to avoid. This highlights the logistical paradox. Expecting an agoraphobic patient to travel to a clinic to learn how to travel is a structural failure. A HIPAA-compliant telehealth model serves as a specific mechanical bypass for this failure. By initiating therapy digitally, the clinician can penetrate the patient's defensive boundary without triggering the hallmark avoidance mechanism. The therapeutic alliance is built within the home, establishing trust before any physical exposure is demanded. From there, the therapist and client plan localized, graded exposures that start at the front door and extend outward. If panic occurs, the patient can immediately return to their digital secure base to process the exposure with the clinician. Telehealth turns the patient's pathological safe zone into a controlled clinical staging area. For this mechanical bypass to work at a population level, it requires a coordinated clinical infrastructure. Coping and healing counseling demonstrates how to scale this intervention across a large geographic area, serving all 159 counties in Georgia. This scale relies on a culturally competent team, deploying over 15 licensed specialists across the state. By providing a mix of LCSWs, OKCs, and LMFTs,
The practice manages complex comorbidities like trauma and depression concurrently. Statewide digital mapping bypasses the geographic constraints of the physical clinic. Evidence-based exposure protocols cannot succeed at scale if specialized clinical access remains restricted by physical geography. In vivo exposure requires highly frequent and repetitive sessions to effectively recalibrate the brain. This necessity introduces a secondary barrier, the compounding financial cost of continuous care. Integrating broad insurance acceptance removes this final friction point. Accepting Medicaid at a $0 copay and commercial plans ranging from $0 to $40 a session clears the financial block. Removing both physical travel costs and prohibitive session fees creates the sustained operational runway needed for deep exposure work. For agoraphobia, a zero-barrier telehealth model provides the structural starting point for evidence-based recovery.